How's it going, guys? We have a medium difficulty question for endocrine, 53-year-old woman, 25 history of SLE, and she has Cushing's syndrome. We're handing you the diagnosis because we have purple striae here. Chronically elevated glucocorticoids will cause degradation of dermal collagen. You get microbleeds into the striae, giving us our violaceous striae here. So we say we know it's Cushing's syndrome. What's the cause? Well, isn't it going to be exogenous glucocorticoid, i.e. prednisone, because we have a chronic autoimmune disease? If you've been following my content, you know I've inculcated this recently. USMLE doesn't have to explicate that the patient's on prednisone. They can just say, patient has IBD, SLE, RA, sarcoidosis, managed with multiple medications. If they tell you prednisone, they're being very easy, okay? So you would just say, we know this is Cushing's syndrome and it's going to be secondary to exogenous glucocorticoid use on a background of SLE. What's most likely to see in this patient? Choice A, decreased pro-opiomelanocortin. Correct answer. So exogenous prednisone is not the same thing as cortisol, but it is structurally similar. So when you give it, isn't it going to induce negative feedback at the hypothalamus anterior pituitary? So CRH, corticotropin releasing hormone, will decrease from the hypothalamus. And normally CRH is going to stimulate the precursor pro-opiomelanocortin, which becomes ACTH and alpha MSH, right? So pro-opiomelanocortin is going to decrease as a result. In causes of endogenous Cushing, where ACTH is high, whether it's ACTH secreting tumor of the anterior pituitary, which is called Cushing disease. Okay, Cushing syndrome is any cause, but Cushing disease specifically refers to anterior pituitary tumor secreting ACTH, or whether you have small cell bronchogenic carcinoma secreting ACTH, you have the precursor, the synthesis of ACTH, POMC, which is also the precursor to alpha MSH, so you can get hyperpigmentation in those patients. In this patient, you wouldn't specifically expect hyperpigmentation. I don't want you memorizing strictly which type of Cushing is more or less likely to present with hyperpigmentation. That's less important for USMLE. This is just about the physiology and feedback mechanisms. And if you think A is weird, then let's just easily eliminate the other ones, right? So choice B, increased renal potassium retention. Okay, more tricky. So I've talked about in my content how chronically elevated glucocorticoids can lead to kaliuresis, which is a fancy word for micturition of potassium. It can lead to potassium secretion in the kidney via a mechanism similar to mineralocorticoids, i.e. aldosterone. Okay, and this is because glucocorticoids have fractional mineralocorticoid effect of the kidney. So if you have chronically elevated prednisone, chronically elevated endogenous cortisol, if it's endogenous Cushing, then they can give you a low potassium in the setting of Cushing disease or Cushing syndrome, doesn't matter. And don't be confused. It doesn't mean aldosterone is high. They'll just give you 12-line paragraph, Cushing syndrome, let's say due to small cell bronchogenic carcinoma. Potassium is 3.2, normal range 3.5 to 5. You're like, why the fuck's potassium low? It's just from the elevated cortisol. So you wouldn't have retention of potassium in this case. If anything, you would have decreased renal potassium retention, increased potassium secretion by the kidney. Wrong fucking answer. Choice C, increased serum CRH. Wrong fucking answer. As I just harped on, you'd have suppression of CRH, not increased CRH. Wrong fucking answer. Choice D, increased serum cortisol is wrong, so very tricky, okay? But once again, if you didn't follow my content, you've done highlight arrows, you'll think this is very easy. Cortisol is not the same thing as endogenous glucocorticoids. If you give somebody, let's say, thyroid hormone, their actual thyroid hormone goes up. It is the same thing. Levothyroxine for T4, triiodothyronine, T3. But it's not the same thing when we talk about glucocorticoids, i.e. cortisol. If you give someone prednisone, you give someone hydrocortisone, it's not cortisol that we're giving. So you give somebody exogenous prednisone for autoimmune disease, you're suppressing the CRH, ACTH from the hypothalamus and anterior pituitary respectively, and then you're going to have decreased stimulation of the adrenal gland, decreased cortisol production, okay? People get this wrong, but it's not hard. It's a down arrow ACTH, down arrow cortisol, holy shit, in the setting of exogenous glucocorticoids causing Cushing. Choice D, wrong fucking answer. Choice C, zone of fasciculata lesion. Absurd answer choice, wrong fucking answer. Okay, so clearly we don't have a cortisol secreting tumor of the adrenal cortex, because we just harped on the point that we clearly have exogenous glucocorticoid on a background of long-standing autoimmune disease causing our Cushing syndrome. Wrong fucking answer.